Good evening to everyone present here with us today. This is Shreyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by your keynote speaker, Doctor, for today's session. With much pleasure and honor, let me welcome a very renowned doctor, Dr. T.N. Ravishankar. Sir is MBBS, DFM, FCGP, PGDMLE, MB Family Physician at Sudar Hospital, Chennai. Now, with the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is vital clues, the art of clinical detection in real scenario. Now, without any further delay, let me welcome Sir to our forum and would like to hand over the session to him. Over to you, sir.
Good evening and thank you IJCP for giving me an opportunity to meet our faculty, meet our members and delegates with some case scenario of interest. I have chosen some cases particularly on two aspects, a social aspect and simple investigations can always give a big clue for us in our practice. That is why these two simple cases has been taken. Every single case in our practice are a lesson for us. And that is why I have taken these cases. This was a male case, male patient. I think you will see the age, 83 years. He presented to the hospital with a decreased appetite, cough and dyspnea, nausea now and then, a bit of abdominal bloating. All these he said he had only for the past 7 days. He didn't need any history of loss of weight or any such nature to suspect that he has got a malignancy or something. That too he presented during the peak of the viral fever seasons. It was almost exactly a year ago or at least 9 months ago that he presented to the hospital with all the complaints, and the first impression was that somebody who is also a diabetic and on OHA for the past 40 years. He seemed to be very lethargic, unable to cooperate, but finally I could convince him to get admitted to the hospital. He had a history of acute kidney injury 20 years back and an hypertension for 30 years. Somebody with an hypertension and diabetes for 3 decades, somebody in the age group of 80 plus, you need always to rule out a malignancy. I think that's the normal scenario in our country. 80 plus, long duration, either he got a malignancy. What was not in favor of malignancy was that he did not have any major loss of weight and all his complaint was of short duration as per his history. His temperature was normal, pulse rate was around 80, BP 130, 70, GCS was 15/15, aspirate rate of 20 per minute and an oxygen saturation and room air was 98%. He was on sitagliptin combination, then pioglitazone, telmisartan along with cilnidipine for his hypertension, also on prolomet, that is metoprolol, another sulfonylurea for his diabetes. Quite a long list of medications, both for this hypertension and diabetes. To come to an organ which is involved, he did not give any major history of altered bowel, but then we could find that he has got an abdomen which was tense a bit, bloated, and which he also accepted. We thought either he has got a lower bowel obstruction, quite common in this age group, probably could be a poor bowel movement, and that could also result. And then with the ascites, we thought a bit of ascites, he thought he got a chronic liver disease. He was evaluated and his count was found to be 5,200, a polymorphs 81 favoring an acute infection, then eosinophil 2 and monocytes 2. His HB was normal for his age, 11.8, in spite of his 4 decades of diabetes. Platelets was 2.5, nothing in favor of any of the viral etiology at that time of. And his urea with 47, creatinine 1.4 was very fairly good for his age and for the long duration of hypertension and diabetes. And electrolytes was normal, 133 was sodium, potassium 4.3, chloride 101 and bicarbonate 20. We always suspect somebody lethargic in old age at 83 plus, we always find that he should be having an hyponatremia. His liver function also was normal, his bilirubin was normal, SGOT, CPT within the normal range, and only thing he also got a little ratio reversal, and the proteins was 6.4, fairly good for his, and all his viral markers was negative. HbA1c was 7.2, and his urine glucose was 3 plus, and the rest of it was within the normal, and his alpha fetoprotein was 0.8 nanograms per deciliter, did not favor any liver metastasis or primary. A CT abdomen was done, which showed an abdominal lymphadenopathy, moderate ascites, omental nodularity, and liver was normal. So again, it went up to the stage of to rule out malignancy because of his age, and something was slowly coming in favor of an abdominal couch. The ascitic fluid analysis, pale yellow, there was a blood mixed turbid with 580 cells per cubic millimeter, which was raised. And classically, the lymphocytes was raised with the polymorph 6 and mesothelial cells were only 12. His LDH was raised, and again his proteins was again raised, all going in favor of a chronic inflammation, that is a tuberculosis etiology. The albumin was 2.6, ADA again was high, chloride and sugars were almost within normal limits. So we were pushed towards a stage of a tuberculosis treatment for him. But then, because of his age, and what you might have seen was his omental nodularity will be attracting any one of us to do a diagnostic laparoscope and proceed for a histopathological tissue diagnosis. But then we had a different thought with 83, why should we intervene? We thought we should rule out every other possibility of malignancy, and then we did a PET scan. Now you can find the time when it was 7/8/2024. Metabolically active supradiaphragmatic and infradiaphragmatic nodes, some of them showing necrotizing areas with mild pleural effusion in both lungs, mild ascites, metabolically active diffuse omental stantrin. The pleural effusion was so minimal, which we tried to aspirate, but we could not do. And then we started him explaining to the patient whether he wants to undergo a diagnostic laparoscope or he would prefer taking an empirical anti-tuberculosis treatment. And the entire family gave a concern for an anti-tuberculosis treatment. They were very confident of this gentleman who was a hard worker for his early days in his life until the last 2 decades, that they opted to go for an anti-tuberculosis treatment with 4-drug regime, was put on for 5 months. He had a 3-drug regime for the next 3 months and 2-drug regime for the next 3 months, and on insulin for the last 6 months. He tolerated well the ATT well compared to others. When he said, why I put down this chart was the patient was on a very, very lethargic stage with poor intake and output, and none of his constitutional symptoms were there. But then when he started him on IV fluids and slowly doing the evaluation, his temperature spike started, and you might see that every day it had been during the late evening, which was a classical for tuberculosis. This patient was put on these 4 drugs and tolerated quite well. I was following up the case since August 2024. And then very, very recently, that was this month on 5th, just to rule out, he's quite fine, improved a lot. All these things were fine, no fever, nothing. His sugars was normal. His weight was gaining what he was earlier. He gained almost 4 kgs of weight. I think I forgot to add on the weight there. And everything was fine. And just to see what happened to the nodes, we did an ultrasound abdomen, which could not pick up anything except that his kidneys had more in favor of a medical renal disease. And a chronic parenchymal liver disease, bilateral grade 1 renal parenchymal disease, bilateral renal, simple renal cortical cyst, and a prostatectomy expected for his age. Something about the presentation of tuberculosis. The most common symptoms is an abdominal pain in an abdominal tuberculosis, though of course this patient did not have an acute pain or anything like that. He did have a dragging discomfort because of the ascites. Constitutional symptoms like fever, weight loss, loss of appetite are present only in 40% of the patient, though he did not have a classical fever but did have fever occasionally. But this weight loss and loss of appetite was his predominant symptoms. Ascites was present in him, that is present in almost 50% of the patients. Peritoneum was the most common site after ileocecal region, though his ileocecal region was comfortable. Of course, the PET scan did not pick up anything in the ileocecal region, and peritoneal nodes were there. Almost all patients present with abdominal pain and abdominal distension. So was our patient. The IGRA has emerged as an important tool for the diagnosis of latent tuberculosis infection, but it was an obvious because of the caseating nodes which was picked up both in the PET as well as the CT abdomen, and all the entire ascitic fluid analysis favored more in favor of a tuberculosis. And the patient's attender opted only for an empirical treatment of tuberculosis rather than going for a diagnostic laparoscope. On ATT, patient recovered, and it is almost since August 2024, and right now he is only on rifamycin and INH for the next 2 months, just tolerating all the drugs so well. And we are fortunate. This case was presented because an 83-year-old man, we did not do a major intervention. Of course, we did an abdominal tapping. We tried to do a pleural aspiration. All these things do have a direct and indirect. The gene expert was done. It was positive, and that is why with a PET scan, we proceeded to put him on anti-tuberculosis treatment. And of course, he recovered so well. Probable abdominal tuberculosis, the narrow bar where we say high ascites, ADA, negative for malignant cells is the most important factor, a negative predictor for putting for anti-tuberculosis treatment. Caseating granulomas not on histology but on an imaging system. Granuloma on histology or other causes are excluded. Necrotizing lymph nodes on CT with non-contributory cytological and biopsy. Of course, the cytology and biopsy was not done, and everything confirmed the presence of tuberculosis, and the patient has recovered and is so fine now. And though he had a little bit of abdominal discomfort, that is why I did a ultrasound abdomen in the month of April. Probably a little bit of liver disturbance due to the rifamycin that he has got, and discontinued for a week and then started back. He is comfortable now. Probably another 2 months of rifamycin INH, I think we should stop it. Judicially trying to put the investigation on an 83-year-old man, not subjecting to for a major intervention procedure. The patient has recovered. All you need is to explain transparently to the family and proceed on with the treatment. In case in 1 month's time, if he had been failed in our treatment, we would have gone in for an intervention procedure to prove the diagnosis with the diagnostic laparoscope. This is the first case which I have presented, and there is the next case. This was another gentleman, 60 years old, Ramamurthy, who had 3 months of dyspnea and bloody sputum with cough with expectoration. He was a hard labor when I saw him first, well-built personality, dark in color, for the reason for almost 30-35 years he was working on the roads, laying down the roads, when our tar was the one which is, today we have a cement road, but then we were having only tar roads for years together, for generations together, and he was working there. His vitals, pulse was 93, temperature was normal, no lymph nodes present anywhere, oral cavity, BP normal, very important with the dyspnea, cough. He did not have clubbing, no cyanosis, no pedal edema, JVP was normal. The laboratory findings was as above, except that monocytes, which was 10%, which doesn't attract generally anybody. With an LFT and an ALP was 112 milligrams. Electrolytes were normal, CRP was 29. They wanted to rule out any infection. Procalcitonin also was then, which was negative. All viral markers negative. Sugar, urea, creatinine, all within the normal range. Of course, he was a diabetic. An ultrasound abdomen was done, which showed a portal vein dilatation 13 millimeters postmegaly, and they gave the indirect clue of left lower lobe mass with pleural effusion. Proceeding on to a CT thorax, confirmed the diagnosis of an ill-defined soft tissue dense lesion measuring 6.3 into 4.7, noted at the left lung lower lobe. The lesion was abutting the pericardium and the parietal pleura, with mild pleural effusion with pleural thickening and enhanced pleural fluid volume of 150 ml noted. Few enhanced nodes noted in the pleural, largest measuring 60 millimeter. This patient was advised to do a bronchoscope or a thoracoscope for diagnosis tissue diagnosis when the patient came away from nearly 300 kilometers to see me. And then I had to proceed on doing a bronchoscope. We preferred a bronchoscope. He was a very perfect, normal gentleman, and we did the bronchoscope and found suggestions of non-small cell carcinoma, and he was put in for a immunohistology also. A pulmonary function test was done earlier, which could not be predictive because of the poor quality. They could not interpret it. And then to prove whether he has got any other spread anywhere, we did a PET scan again. PET scan did not show any metastasis at anywhere. Of course, there was a bit of degenerative changes in the spine and something favoring the Paget's disease. The man had been working in a hard labor on the streets with prone to be having an occupational hazard. And 3 months he had been going around from doctor to doctor with the complaints of dyspnea, cough with expectoration. The unfortunate situation was nobody had did a X-ray chest. Everybody had been trying to put him on some bronchodilators and antibiotic at 2 different places, and then he went to one of the corporate hospital attached to a medical college where he did all the previous investigation, and they clinched onto the diagnosis of a left lower lobe malignancy. 3 months he had been loitering around with the symptoms of hemoptysis. So probably the disease had been much earlier, that nobody ever thought of trying to do a simple X-ray chest and do it on lookout for it. There is a social aspect on this patient also. For 3 decades, he had been working in the fumes. He had been working on the tar roads, laying down the tar that has been emitting lots and lots of fumes, which could also get deposited in his lung. Maybe people in the anatomy could recollect that they would have kept lung anatomy, normal lung, abnormal lung, lung which had been exposed to smoking, lung with bronchitis, emphysematous lung, and all these things. But this gentleman, for 3 months with symptoms, was not evaluated. He came so late. Of course, when there was not much, though there was not much secondaries, the oncologist said his lifespan will be maximum another 6 months to 1 year. That too in the present era of lung malignancy, which has lots and lots of treatment, trying to detect so late in his lifespan after having presented a symptom for 3 months and putting him on an anti-cancer drugs so late with all the risk involved. This X-ray was taken very recently after even having had 2 doses of chemotherapy. With 2 doses of thermotherapy, I am sure you could see the lesion slowly vanishing from the lower lobes. But of course, he has got features of chronic bronchitis, emphysematous lung, and all these things. This case has been put up mainly for people like us to think around on the social aspect, on looking around on the occupational hazards that any of the person's occupation can present. Today, somebody working in the IT industry is also put to an occupational hazard. If they don't have a proper ergonomics furniture for them, they are bound to get in for neck pain, cervical spondylosis, fibrofasciitis, radiculopathy, and all these things. Somebody working with their knowledge, somebody working with their computers can have an occupational hazard. Think about a gentleman who are forced to go around with doctors not even opting for an X-ray chest. We cannot always blame the medical fraternity for the reason these patients who come from the villages or too small a town will always prefer to get a treatment for some time without any investigation. But then it is a responsibility of the medical fraternity to tell them these are the investigations that need to be done to prove the diagnosis before we could cure him or catch him early with any problem. It's our responsibility to convince the patient on the issue and then finally take it forward with the patient. And that is how This patient right now had had 2 doses of chemotherapy, which he tolerated so well. I have presented 2 patients of 60 plus, one 80 plus, both of them tolerating the harsh treatment that we provide for tuberculosis and chemotherapy. And this second gentleman was so happy that with his nebulizations, he is happy at home with the chemotherapy once in 10 days. That said, another 4 chemotherapy to be done. And let's hope his lifespan is at least another 1 to 2 years. Of course, to give him his family history, he has completed his family life, and he had his daughters also married. But then it's at this age that they will feel like sitting in an easy chair and enjoy the life what they have undergone in the last 4 decades. But then at this point of time, he is detected with tuberculosis. With malignancy. Another thing that I would also wanted to point out in this case was the monocytes of 10%. We always ignore that one investigation of monocytes or basophils or whatever it is. Just go through the polymorph lymphocytes and eosinophils and then correlate with certain things of MCH, MCHC, and all these things. But monocytes is another important one which can predict an autoimmune disease or a malignancy that is there in a patient. Something about 8% of monocytes. Try to look into the history of the patient, try to find out if there is anything in the family history favoring an autoimmune disorder, or look out for a place where he could have had a malignancy. Somebody working in the fields with smokes and fumes, I think you will have to suspect a malignancy in the lung. That is also possible. Somebody who's working, some woman working somewhere in the kitchen where they had been using the older system of cooking, they also can always have something in the lung. It is ideal that we suspect in a woman whose lifespan or whose life history of life is been there living with a smoker, either with the parent or the husband, or somebody who had been working in the wooden firewoods for the cooking and all these things. And monocytes is one here, was an indirect clue. When the patient came to me, I was fascinated looking at the monocytes and tried to go into the records, and records keep saying that monocytes is one of the diagnostic feature for any malignancy. I think I have presented 2 cases worth trying to learn something in our day-to-day practice. Aged, less intervention, rule out certain investigation, convince the patient's family or take them into confidence, get their concern, proceed with empirical treatment, and if it is successful, proceed on and complete the treatment. The second patient, somebody who has got an occupational hazard, think in that line. Even on the first day when they are presenting, most often these patients are high tolerance that when they present, they would already have had the disease spread around. Somebody who's working in a hard labor, depends on his daily income from the village side. I think the day when he presents to you, I think you need to thoroughly evaluate, convince the patient for all the necessary investigation, put them on it, and try to diagnose earlier and proceed on with an appropriate treatment for them. Prevalence of non-cell carcinoma is the most common type of lung cancer, accounting for about 80% of the lung cancers. It's a slow-growing one. See, we have missed it on this patient. The risk factor is known. Shortness of breath, weight loss is the typical symptoms. X-ray with a good X-ray could have been diagnosed earlier. Treatment options are there. Prognosis of this has been with an early detection, but none. This patient is in the late stage, and that is why this patient has been presented to you for a lesson for all of us. Monocytes of the type of white blood cells that play a crucial role in the immune system, helping to fight infection and clean up cellular debris. Cancer, lymphoma, multiple myeloma, and sometimes a lung like this also has been, the records are there available in the history that you could go through with most of the websites. And thank you for listening to me for these 2 interesting cases which I have gone through of good interest to every one of you. Thank you very much. I'll be willing to take up some questions.
Thank you so much, sir, for this wonderful presentation. We do have some question if you like to take that up.
Yeah, please.
So, the first question is, in a patient with non-specific fatigue, what vital clue help you distinguish between anemia hypothyroidism, and chronic infection.
What test? Can you go ahead and repeat the question?
Yeah.
Repeat the question, please.
Yeah. So the question goes like this: in a patient with non-specific fatigue, what vital clue help you distinguish between anemia, hypothyroidism, and chronic infection?
Chronic infection, somebody will have pain, fever of a long-standing duration. Hypothyroid, I think it is very easy to go around with overweight and all these things. These patients will definitely have things. And another one was, the first one was
First one was anemia.
anemia. It is quite obvious if you do a clinical examination. Somebody pale tongue, you always look into the eyes, and that patient, if it is going to be woman, it is more in favor of anemia or hypothyroid. Then hypothyroid, the patients will have a menstrual disturbance and all these things. An anemia patient is likely to have an exertional dyspnea, history of having passing menstrual too often, or the flow will be very high. All these things will be there. Any chronic infection, the weight loss, the patient will be attributing it very clearly to the time of the onset of fever. They always say, even in 5 days of fever with the poor intake, they say, I have lost 5 kgs of weight and 10 kgs. They will exaggerate. In that way, the chronic infection is there. And always ask the patient to take the temperature chart and come to you. These are all non-invasive symptomatologies, which will help you to find out from the patient symptoms as well as signs that you can pick up, label it which part of the organ is involved, and that will be easy to go in for the further investigations.
Next up, sir. When faced and recurrent cough and sneezing, what historical clue can differentiate between asthma and cardiac failure?
Obvious cardiac failure patients will not be able to lie down flat and sleep in the night. He will have an orthopnea and then complaints, and one day he may be able to lie down for half an hour, 1 hour, and 2 hours. Beyond that stage, they will start coughing and will have dyspnea and will never sleep the whole night, which is going to be recurrent every night until he goes for a treatment. Somebody with an allergic disorder, only when he is going to be exposed to the allergens, he is going to cough. And most of these allergen patients will always have cough early in the morning when they get out of the bed. They go to the bed, and the bed, if they're going to have the foam, they're not going to have the problem. And they're going to have somebody with a natural bed. This is going to be an stimulating allergen. Or today they are trying to use any mosquito repellents. They keep the doors closed with poor ventilation or cross ventilation in the night. That could also aggravate the sneezing that you can have. Very easy is the orthopnea, pedal edema, unable to walk, unable to climb stairs, and all these things in favor of a cardiac issue.
So there's one last question. How can nail findings point you towards a systematic disease before lab result come back?
Anemia is the one which can easily find from your nails. Brittle nails with calcium, hypothyroid, thyroid disorders are there. Anemia can be picked up in the nail, and you have the spot in the vitamin D deficiency in the nails that do happen now and then. And for this, that will be more often seen in the children. The small spot that you have in the nail, the white lines that will be there, that could be easily picked up to go in for a D deficiency. Most of the deficiencies in the system can always be correlated with the nail.
Thank you so much, sir, for answering all our questions. That's all from our audience. So before concluding, any take-home message from your end?
Clinical informations from the patients are very, very vital. If you can take a good history, and you can always need to convince and talk to the patient. Both these cases, one for an empirical treatment, we could convince. The second was to go in for an evaluation, doing a bronchoscope and all these things. See, you need to communicate with the patient, say which organ is involved, or what is the likely diagnosis from your side. Be transparent, try to convince them to do all the investigation earlier and go in for an early diagnosis and proper treatment.
Thank you so much, sir, for joining us today. It's our pleasure to have you here. Thank you, sir. With your permission, I would like to conclude today's session.
Thank you. Thanks a lot.
Thank you, sir.